My name is Andy Beck. I am a general pediatrician at Cincinnati Children's and am really excited to be able to present this topic along with some friends and colleagues from across Cincinnati on a topic that we find so important. It's been a really wonderful and impactful start to this national conference, and our hope is to add to it. Over the course of the next 45 minutes or so, you'll hear from a few additional people, additional colleagues. I'll start by introducing Dr. Ndidi Unaka. She is a pediatrician and associate professor in the Division of Hospital Medicine here at Cincinnati Children's. She has a ton of different roles across our hospital and across our community. One of them is co-leading our Health Equity Network, which supports the equity-oriented improvement effort of clinical teams from across our hospital. She's also the medical director for quality improvement for our Medicaid ACO. Dr. Carley Riley is a pediatrician and pediatric critical care physician. She is on faculty in that division here at Cincinnati Children's. She is also a faculty co-lead for population and community health. Her research is dedicated to improving equity in health and well-being, with a long-term goal of reducing the burden of health disparities, addressing the root causes and implications of suffering, and fostering thriving by developing interventions using innovative science within cross-sector community healthcare collaborations. Ms. Bond-Lewis is a litigation partner at Dinsmore and Scholl and is also an executive on loan to the Cincinnati Children's Hospital Medical Center. In this capacity, she is refining the strategy and developing the operational plans for what we call the Community Table Initiative, which consists of families and leaders from across multiple sectors in our city, united around the goal of eliminating or reducing systematic barriers to that which stands in the way of health and well-being for Cincinnati children and families. And finally, Dr. Kahn is a professor of pediatrics and associate chair for community health in the Department of Pediatrics here at Cincinnati Children's. He serves as executive lead for our hospital's community health strategic plan, which aims to help ensure Cincinnati's children can pursue their future to the best of their ability, and that we can see our city's youth with the best possible outcomes through strong community and family partnerships. We are so excited to present today. And as a reminder for what we heard earlier in the day, what we will strive for in this session is those factors, those characteristics of a safe and brave meeting, which were presented at the start of the session earlier this morning or earlier this afternoon. There are a few ways to engage while in the room. Everyone has capability of chatting in or providing emoji reactions. There's also, of course, the opportunity to promote and share what you learn, what you think on social media. But over the next 40 minutes or so, what we would really like to do is highlight a few aspects of our community-centered, community-connected approach. We will highlight how we are building toward an institutional approach that is truly community-connected in the pursuit of health and well-being equity. We'll talk about how we're building population health capabilities inside the hospital and ensuring that those capabilities align with, complement, and intersect with methods that include co-production with families and community partners and enable what we truly strive for, a multi-sector community transformation in the name of child health equity. What I'd like to do, though, is start with what we call an equity minute. One of the things that we often will do at the start of our meetings, both inside the hospital and in partnership with community, is think about a equity-oriented concept, frame, or thought that really should help us move in the direction of the goals that we share. This is an example of an equity minute that we pulled from a meeting of clinical teams focused on equity-oriented improvement just the other day. Many of you on this call are likely familiar with the longstanding systematically racist policies and structures that were promulgated by redlining. Many of you have probably seen this website from the University of Richmond, which highlights redlining maps from all across the country. This is the best redlining map that I could identify from that site. and that is in circulation for the city of Cincinnati. It is quite faint, but fortunately, there was a project by a Princeton University student, a member of the eviction lab, who tried to recreate this redlining map using ArcGIS, highlighting where neighborhoods were, illustrative of redlining from that 30s era practice. And what you can see is, and what is likely true across cities in this country, is that the very real ramifications of redlining persist to this day. A couple of the neighborhoods that were highlighted, one that was a redlined neighborhood just around the corner from the hospital had a life expectancy of 69 years. A neighborhood that was just 2 or 3 miles from that one that was in green or blue had a life expectancy 15 years greater. And what we see here is the location of Cincinnati Children's Hospital, right in the thick of neighborhoods that have long experienced decades-long ramifications of structural racism. And so into this reality, and with this equity moment spurring us on, we've long sought to figure out our approach to building an institutional and aligned effort in promotion of health equity. As I think through this, I'll go back to the reality that Cincinnati Children's has an important mission and vision. Stated firmly is our vision that we will be the leader in improving child health. Central to this vision is this idea that we will be the leader in improving child health, not child health care. That requires us to think outside our realm. In 2015, the hospital took this vision for improving child health and doing so in partnership with community to outline a strategic plan for 2020. Now, this strategic plan probably would look familiar to many of you, but there was an important new aspect of it that had not previously been listed alongside the others. We've long sought to deliver exceptional, safe, and affordable care. We've long thought to transform child health through our research, through a culture of discovery, translation, and learning. And of course, we've sought to improve the lives of children everywhere by creating deeper connections with families, realizing our full potential by engaging, inspiring, and enabling our employees. Those have long been things that have been central to our mission. But what was new and written into that strategic plan was that we would also help Cincinnati's kids to be the healthiest in the nation through strong community partnerships. This idea that we were at our core a city hospital beholden to those that lived in our backyard. Now, this didn't occur overnight. There had been years leading up to this moment, leading up to community being centrally located along with care, research, and education. Over the course of many years, we've gone from thinking about certain conditions like infant mortality, asthma, injuries, or obesity, to aligning those with a community-centered focus. Fast forward to today, on the heels of the 2020 strategic plan, we're pursuing an initiative called Pursuing Our Potential Together that will take us to 2033, the hospital's 150th birthday. Central to this focus continues to be community, and highlighted within it is a focus on equity, children having the opportunity to reach their full potential, families that feel safe and supported, and pursuing a value-oriented focus which helps us get where we need to be. Along the way, we've identified a key set of enablers, from data and analytics to improvement science, activation, and co-production, which Dr. Riley will speak more about in a moment, thinking about distributed leadership that includes capacity building inside and outside of our hospital, and aligning finances, bridging to population health with those on from Medicaid managed care roles. And this is what it looks like. Again, community centrally located along with care, cure, and culture. And between now and our 150th birthday in 2033, Cincinnati Children's will be pursuing our potential together so that kids can pursue theirs. And you can see how this has been written into our generational focus on equity. We're going to come back periodically to this orienting diagram, orienting figure that helps to locate the work that you'll hear about over the next several minutes in alignment with one another. So you can see our top level measure, our goal for children pursuing their full potential. We'll talk about work related to equitable and excellent health outcomes, a pathway to a full potential, and families that feel safe and supported. We'll highlight some enablers that help us move forward faster. But let's start with thinking about population health capabilities inside the hospital, focused primarily on this concept of equitable and excellent health outcomes. At the start, I showed the slide of our redlining maps. I highlighted differences in life expectancy across neighborhoods. And I can tell you that that degree of disparity, that degree of inequity extends to multiple other child health conditions. This is a figure looking at the inpatient bed day or admission rate for children from across Cincinnati. On the y-axis are the 80 or 90 neighborhoods that compose our city. And on the x-axis is that admission rate. And what you can see is the sheer variability as you go from top to bottom, suggesting a number of inequities that characterize children living in our community. When we look at this by certain variables that we can capture from the US Census, we see stepwise gradients as it pertains to race, illustrative of the intersection of racial segregation and discrimination in where and how people live across Cincinnati. You see other measures relating to transportation access, to children living below the federal poverty line, to households requiring federal or public assistance, and to housing-related measures illustrative of real gaps. These are neighborhood disparities, but they extend to race. This figure is looking at all admissions over the course of a multi-year period to Cincinnati Children's Hospital for kids from Southwest Ohio. And what we did with this figure is begin to capture in absolute terms how many admissions across certain conditions would need to be prevented among individuals identifying as Black for Black individuals in Cincinnati to have the same admission rate as their non-Black peers. So as an example, if you look at the top of this figure, there were 294 excess hospitalizations among youth identified as Black compared to those who were not identified as Black. We would need to prevent nearly 300 asthma admissions a year to arrive at an equitable outcome for asthma. And you can see that this list highlights a range of conditions with opportunity for improvement from asthma to mental health outcomes, even down to COVID-19 listed toward the bottom. Now, we are moving actively in the direction of achievement of equitable outcomes by neighborhood, by race, by socioeconomic status. And I'm going to turn it to Dr. Ndidi Unaka to begin to illustrate the ways in which we're doing so.
Thank you, Andy. And thanks for all of you being here today to hear a little bit about what we're doing here in Cincinnati. So I'm going to talk a little bit about the Health Equity Network, which is the vehicle that we are using to really try and achieve excellent and equitable health outcomes for our children and adolescents in the Cincinnati area. The global aim of the Health Equity Network is really to have zero gaps in child health outcomes by race and socioeconomic status. And our current focus within the HEN is to really decrease the gap in total hospitalizations for Black children compared to all other children. And I will show in subsequent slides how that gap persists across physical health admissions and mental health admissions. And then we are also hoping to really ensure that our Health Equity Network teams are progressing along a roadmap of improvement as they're using quality improvement science to really help address these equity gaps. We have identified key drivers that we think are critical to really addressing the equity gaps that we see among our children here in this area. Those key drivers include providing the right care at the right time, in the right place, and in the right way, really addressing negative social determinants of health and enhancing positive social determinants of health and assets within communities, really ensuring that we have effective and seamless communication connections across the health system and between health and community systems, building trusted relationships and supporting partnerships that enable impactful, collaborative interactions between care team members, patients, families, and community partners. I think it's definitely incumbent upon us as a healthcare system to prove our trustworthiness to patients, families, and community partners. We want to ensure that we have an activated, accountable, and aligned leadership within our hospital, and that we have a fortified learning network model. The Health Equity Network is actually a joint effort between our hospital's Community Health Initiative and HealthFind, which Andy referred to earlier, which is our hospital's accountable care organization. And we are using a learning network structure to really accelerate improvement. We currently have 4 teams that are involved in our Health Equity Network. We have our adolescent medicine team that is really working to decrease equity gaps in hospitalizations in adolescents with various mental health diagnoses. We have our endocrinology team that is working to reduce hospitalizations for children and adolescents with type 1 diabetes. We have our asthma team that is working to reduce hospitalizations among children with moderate to severe asthma. And finally, we have a neonatology team that's working to reduce readmissions to the hospital in preterm infants that are born and cared for at our university NICU. Next slide. And so just to touch on some of the ways in which we are really trying to do improvement work within the Health Equity Network, our teams meet on a monthly basis. And we have a couple of different interactions with our teams. We have a monthly action period call where teams are actually sharing their learnings, their successes, their challenges. They're talking about the various tests of change and the interventions that they've co-produced with other key stakeholders. And then we have a monthly learning lab, actually, that we now refer to as solutions labs, where we are focusing on common drivers to accelerate testing. So for example, we've had a really strong medical legal partnership that for several years has been primarily based in our primary care clinic. We did a solutions lab focused on our medical legal partnership, and we used that as an opportunity to start scaling legal aid referrals from all of our HEN teams, which has been really exciting. We've had a solutions lab focused on social risk and needs screening, how to deliver anti-racist care, the importance of identifying leading process measures that we think are related to our outcome measures. And then Carley will touch on this, really thinking about how we actually do co-production with individuals with lived experiences. Next slide. This is just a look at our data. So just to orient you, on the x-axis, we have time by year, and on the y-axis, we have the rate of admissions. We are looking here at both physical health admissions at the top per 100,000 children 0 to 20 years of age that live in our 8 Southwest Ohio County region. And on the bottom, we have mental health admissions for per 100,000 children and adolescents in the same region. As you can see at the top for physical health admissions, we've noticed that we've had some new baselines in physical health admission rates amid the ongoing phases of the pandemic. And then we've also seen, as it relates to our mental health admissions, early evidence of decrease in mental health admission rates for both our Black patients and all other patients. And then on the other side, on the next slide, you will see that we've seen a decrease in the gap between mental health admission rates for our Black patients compared to mental health admission rates for all other patients, which is a really exciting signal of the work that we're doing in the Health Equity Network and in our institution in general. Next slide. So just want to share some team highlights for our adolescent medicine team, who's been focused on reducing mental health admissions for their patient population in the teen health clinic. They have actually instituted preventative behavioral health visits. They have seen over 500 children in the last 8 months for mental health preventive visits, which is exciting. They have also referred over 30 patients to legal aid, and our legal aid partners have been addressing housing and educational needs for these patients. For asthma, we are actually building an asthma learning health system, and the Asthma HEN team is embedded in that work, really trying to coordinate asthma care across our across the area with key community partners. And our asthma team is also updating the referral process for housing supports to try and abate environmental risk for kids who have asthma. Our endocrinology team is doing some really incredible work. They have actually identified and are working with diabetes-focused community health workers, and they are really focused on equitable deployment of diabetes technology, specifically continuous glucose monitoring and insulin pump usage. And finally, our neonatology team is aligning data across 2 systems, the adult hospital and our children's hospital, and they have a bolstered focus on breastfeeding medicine. And they're also doing some journey maps to ensure that families feel like they have the information needed to be successful upon discharge. These are just a couple of other team highlights. So this is a control chart showing the signal of decrease in mental health admissions for our adolescent medicine patient population, which is really, really exciting. And then finally, we have a chart that's showing the increase in equitable use of continuous glucose monitoring among youth with type 1 diabetes. You can see the gap between Black patients and white patients, and we are narrowing that gap as we try and ensure that our Black patients have access to the technologies that could be critical to their glycemic control. So in terms of looking forward, we're hoping to promote connections across the health system and with community systems, including schools, social service agencies, and city government. We're hoping to build out population health dashboards. We talk a lot about key performance indicators, but we are really looking to build key equity indicators and have that be visible across our institution and to our community partners. We're hoping to add 5 additional health equity network teams. So we're going to have a ramp up this fall with formal entry of the new teams in January of 2023. And, you know, I think we really will continue to navigate this tension between having patients to address challenges that have been in place and entrenched in our system for hundreds of years, and also working under the urgency to act and achieve the equitable outcomes that we're hoping for our kids in Cincinnati. And then we hope to meaningfully connect with patients, parents, and families, and really adhere to the tenets of co-production as we do this work. And with that, I will pass it on to Dr. Riley.
Thank you, Ndidi, very much. So now I have the opportunity first to speak for a handful of minutes here about our approach to co-production with families and community partners. And as Andy, Dr. Beck had mentioned in the beginning of this presentation, co-production with families is seen as a key enabler. And in fact, I'm going to go a step further, and as Andy advanced to the next slide, I'll say it's just embedded in the mission. It is a part of the core of the way that we work. Our mission, you can see it here, our mission is to bring community members. This includes children, families, community and civic leaders, educators, social service providers, faith leaders, healthcare providers, researchers, and others together to collaborate, learn, formulate and answer questions, encourage discovery, and implement findings to co-create an environment where children thrive. And as we have been on this journey of co-production here in Cincinnati, we've actually co-produced our own understanding of what do we mean when we say co-production. And we produced a guide out of this work that we can certainly make available. And in this, we've laid out some just general definitions, and then alongside that, some ways of getting started in co-production. And so co-production is an approach where families, patients, partners, providers, and community members work together, sharing influence, skills, and experience to design, own, and analyze outcomes and solutions. And we see this as essential to the pursuit of equity. And if you advance one more, you'll see this is one piece of the guide in which we call out that if we want to achieve equity in health outcomes and communities, we must include those historically excluded from resources and decision-making processes. When we co-produce, we address issues and design solutions inclusively and collaboratively. And as we've done this work, we've unpacked that understanding of co-production to explicitly call out utilizing anti-racist frameworks, creating distributed leadership, and sharing power. And you'll see that over the next handful of minutes. As we looked to continue to build our understanding and our practice of co-production here, we looked to the words of others, such as Rosa Gonzalez with Facilitating Power, in which she said the status quo practice of current systems that have been historically designed to exclude certain populations, namely low-income communities, communities of color, women, youth, previously incarcerated people, and queer or gender nonconforming community members. This understanding is important because if concerted efforts are not made to break down existing barriers to participation, then by default marginalization occurs. And for this reason, amongst others, we see that co-production is essential for the pursuit and achievement of equity. And we've called this out in a publication that we released last year in Learning Health Systems, in which we co-produced a list of 7 core practices for the pursuit of equity through a learning health system. And you can see them here. First, as you've seen in our mission, we recognize the essential need to establish principle. So positioning equity as an essential focus of the learning health system. And then, as both Andy and Ndidi have called out, measuring for equity, as Dr. Unaka and Ndidi called out, that tracking data that matter to drive and sustain success. And that we've had to do this by specifically leading from lived experience, ensuring that people with lived experience are the ones who are leading the work. And that we do that through the practice of co-production, where we design, create, learn, act, and then sustain together. And then that necessarily begs that we must redistribute power. And this needs to be an intentional and sustained process by which we reallocate power and leadership across the system. And recognizing that all of this is very hard, we will practice a growth mindset in doing this by cultivating an environment and expectation for growth. And then, as both of my colleagues have already called out thus far, that it is essential for the pursuit of equity that we engage beyond the healthcare system and catalyze change across all of the systems that produce health. Moving forward, we have recognized that there's much that we've learned along the way in what does it take to be successfully in a co-production relationship with others. And this is really a journey, and it's a journey that takes place along an entire continuum, from just the very beginnings in which you're beginning to prepare and explore, to then beginning to engage and build together, and then ultimately sustaining and supporting relationship and co-production. And you can just see here, this is a picture that we've placed within the guide that we co-produced with Design Impact and others, in which we have called out specific questions that we need to ask ourselves along this pathway to ensure that we're really adhering to the principles of practice of co-production. And as I mentioned, there is a guidebook that we've created that also embeds within it different tools, different exercises and activities, practices for those that want to begin or strengthen their practice of co-production. And then we've also included a series of measures so that we can actually measure our own success and progress in our efforts to co-design and co-produce. And this, as I said, has been an essential enabler embedded within our collective practice within this work. And I'm going to showcase a bit more of how we've realized that by talking about the work of the Safe and Supported team. So I have the privilege of leading the Safe and Supported Families team, which is a multidisciplinary team in which we are really working outside the walls of the hospital, building cross-sector community partnerships with children and families at the center, in which we are specifically working to try to design solutions that nurture the positive influences of health and either mitigate or eliminate the negative influences of health. And if you move forward, you'll see that we've developed out of this a real portfolio of initiatives that we are working to really integrate with thriving children and youth at the center. And you can see them pictured here. We've got System to Achieve Food Equity. This is an effort really to tackle and improve food security and food equity across the city of Cincinnati. We have Work and Social Determinants of Child Thriving, which Alicia Bond-Lewis will speak more to, in which we're seeking to improve economic mobility and emotional well-being. We have this endeavor, All Families Thrive, in which we are seeking to reduce child abuse and neglect as a downstream effect, in which we're looking upstream to support families moving from suffering and struggling to thriving in an effort to decrease the likelihood that children and youth will experience neglect and abuse. And then we've been doing some catalytic innovative work with really community leading the way to understand community trauma and healing. And I'm going to speak now more specifically to the work of SAFE. But as I do so, the principles and the things that I kind of bring out in that work, you can know that we are weaving that throughout all of this portfolio of work, in which we're really seeking that every child grows, develops, plays, learns, and lives in environments that foster their thriving and limit their suffering. And to improve that child thriving, we're creating this robust cross-sector community-based learning system that's really focused on the determinants of child health and well-being. So if you move forward, we'll start with food equity. So it was back in March of 2020 when we actually first leapt into work in food security and food equity as a team. And we hadn't really previously been engaged in the food system, but when the COVID pandemic came upon us and stay-at-home orders were put in place, our community-based team turned to our family and community partners and asked them what were their greatest worries or needs and what were their greatest hopes. And that led us into food equity work. Andy, if you click forward one slide, you'll see some mapping work that we did early on with partners of 8451, the data analytics hub for Kroger, in which we specifically mapped anticipated need for food or emergency food access against the distribution system that was being built at the time in response to the COVID pandemic, largely as a part of the Cincinnati public school system, but also incorporating other sites in the community as well. The shading of the neighborhoods is really based on childhood poverty. And you can see that there's shading anywhere from that light white to dark brown, the darker colors being areas in which there's greater burden of childhood poverty and therefore more likely to be greater need for food services. And then the green that's overlaid that is the area within 1 mile walking distance of food services that were stood up at least 3 days a week. We were able to look at this map and bring that map to a gathering that was being pulled together by our council member here in Cincinnati of over 100 stakeholders in the food system and show them this map. And that we were able to note that there were some key equity gaps as to where food was being delivered and where there was likely to be food. And many of the providers immediately pivoted their distribution such that they then flooded those areas with food resources and then sustained that to this day. At that same time, we were turning to our family and community partners, as I said, and if you click forward one, you'll see a Pareto chart from this very first week of us really turning for community insight. And you can see that the most commonly cited need from families was concern really around social connectivity. And the second was food. These top 5, 6 different needs that were called out, that's really what shaped the work then that we as a team set out to do. We set aside the book of business that wasn't relevant to the community or the families at the time, and instead turned ourselves to working on these needs in response specifically to family and community voice. If you move forward one more slide and you keep clicking through, what we found was that in working together in this way, there was this emerging learning network that we wanted to nurture and now really exists with our true north being that all 66,000 children in Cincinnati have the food that they need to grow, develop, learn, and thrive. And you'll see this emergent network pictured there, which includes academic, government, public service, and food system partners all working together towards that true north. We move forward again, Andy. We have started to really develop the key elements of a learning system or a learning network, in which we then sought out over the first year of our working together to improve food security for the children and families across 3 pilot neighborhoods by 10%. And again, developed a key driver diagram in which we collectively together identified the key drivers that we all needed to work together to improve and service to that aim, with family and community-led design at the top. Moving forward, you'll see that as a key part of us being able to accomplish really the transformation of the food system here in Cincinnati to achieve real food equity, we had to focus on distributing leadership away from a centralized hierarchical way of leadership to one that was really distributed across our entire network, and then therefore reallocating power, including decision-making around resources. If you move forward, you'll see that we set up a structure in which we really called out neighborhood leadership as really the top governing body within this entire network. And we gave them really the authority to make decisions and determine where the resources went in order to improve food security. And we did this through multiple different mechanisms, including something we called Shark Tank. And so, Andy, if you move forward one, we had an initiative in which we had community proposed initiatives that were then community informed, led, and then evaluated in each of the different neighborhoods. And we're currently wrapping learning systems around each of them. We've now pushed out over $250,000 of money into these neighborhoods that was under the control of those neighborhoods as to what was to be done within those neighborhoods to improve their own food security. And we're now learning from those endeavors as they're underway. Moving forward, we've recently had a summit in which we've looked back at the last year as a network, and we started to look forward, and we've recognized that shared aims, democratized data, co-production, distributed leadership, shared power, and systems thinking collectively is what has led us to be able to produce early catalytic change and signal that real transformation may be ahead. And finally, as I close, I'll say we've now looked together to navigating our future so that we have the entire SAFE network, now all of the partners involved now working together to identify what our future direction is going to be. And we've recently made these recommendations for the network to now affirm together and then determine how it is that we will achieve them together. And in all of this, we're really poised to be able to achieve some unprecedented results. We have to apply novel approaches and methods together in order to do so, in order to really produce excellent and equitable health and well-being for populations. But we're really now transformed in our work together with families and community partners to really to create and sustain some really important transformation in the complex systems, such as those that produce food security, economic mobility, safe homes, and thriving for children. And with that, I get to transition, I think, to Rob and Alicia to speak more to what that work is looking like.
Thanks, Carly. So as Carly noted, in order to improve outcomes for children, we need to work with others in the community. And so to that end, in 2020, the community table was established. Next slide. And as you see on here, the community table consists of a cross-sector of community and business leaders throughout Cincinnati. And they are working collaboratively to create scalable solutions for systemic issues. And what's unique about this community table is that it's not just leaders from the various organizations, but you also see a family representative as well as a student representative. And that gets to the heart of what we've been talking about with co-production with community and also with families. And another unique aspect about this community table is that it's not a project, it's not a program, and it's not something that we're doing to create new things, new initiatives for the community. Rather, our goal is to really change how these organizations are working together. A lot of them are currently siloed. And so by joining forces, we're able to have a deeper impact in the community. And it's really to revamp the current system that's used by the families. Next slide. And here you'll see our shared theory of action. So for all children to thrive, we're focused on 4 E's. economic mobility, emotional well-being, educational success, and equitable health. And on the right, you'll see the various metrics that we're using to achieve these outcomes. So we're looking at whether basic needs are met, humane housing, meaningful work and wealth, nurturing homes and community, lifelong learning, and a sense of belonging and civic strength. To that end, another thing that we're doing is creating a community data dashboard with these organizations. So taking the data that they have and creating this dashboard so that we've got a bigger picture of what's going on within our community. And our goal is to start at a neighborhood level and then expand it to a city and then county level. And with that, I'll transition to Rob, who will share about another effort that's going on in the community, specifically with our government.
Great. Hey, everybody. Thanks so much. This is the final slide. I think the one seat at the table you might not have seen filled is city leadership in terms of government and public sector. So this is our next frontier. I'm actually sitting down at City Hall because there's about to be a meeting in which we're bringing together our health data and the city's data together for the first time. What you're looking at on the left is a geospatial map that brings together 4 elements of data. One is around health, housing code violations related to health, a second around asthma, ER, and admissions, a third chunk around crime, and a fourth chunk around mental health admissions. And together we're looking at where the unique and combined spots are that are high areas for focus. And 3 city council members are bringing together representatives, almost 40 organizations in the next hour to try to understand the data, make sense of underlying causes for each, and then most importantly, think about underlying root causes to all 4 and sort of increase the alignment, much in the way Carley has led in food equity, is now spreading that kind of thinking across sectors and convened and co-led by the city to bring to bear all of their services like police and building and housing and public health as well. So continuing that journey from sort of early health inside the hospital and gradients there, all the way through the community work to engaging senior leaders and now ensuring we have public sector behind it. And with that, I'll turn it back over. I think Andy's going to wrap us up.
Yes, thank you, everybody. And we wanted to make sure that we included our contact information here. I'll just leave that on the screen for a moment, and then I'll take down the share so that we can all see one another for a few minutes of discussion. I have been trying to navigate some of the chat, but would love to ensure that people have an opportunity to ask questions, and then we can go back and forth as we would love to learn from you about your thoughts and reflections from our presentation. Thanks so much, and thanks for participating in this really wonderful national meeting. Maybe that first question that we could go back to from Corey Bradley about arriving at theory and understanding of barriers. I think this question probably goes back to one of the early slides that we showed around our key driver diagram. And I think I could extend that to the key driver diagrams that we shared and that really form the basis for the theory for action for our work. I'm happy to start with some reflections, but would welcome others to weigh in too. That first and foremost, we think of that theory and those diagrams as living documents, that or a living set of those factors that influence the aims that we're trying to achieve. And so, truth be told, each of those driver diagrams has evolved significantly over the years as we've learned and as we've engaged with partners, parents, and families. And I think that's been a pretty key part of our process, but also being prepared to go back and understand where perhaps we need to add a driver, amend a driver, or change, or perhaps eliminate one. So the arrival, I think we have a consistent practice of co-design. We look to the literature when there is literature. We look to our partners when we need that expertise. We look to our patients and families for what they value, and we arrive at a theory that by definition can evolve. Other additions, I'm just looking to my co-presenters.
Yeah, Andy, I'll just build on that and affirm everything that you just said, and then also just mention that we have many mechanisms for ensuring that theory is co-designed and co-iterated. And some of those are that, we have community partners who are embedded on teams. And so they're actively working, alongside all the other members of the team and contributing in that way. We also do a lot of one-on-one engagement. We've developed many deep relationships over time with community and family experts whom we really rely upon. We have regular listening sessions in which we have opportunities for really reflection and co-creation together. And then we will have, as we move the work out into spaces, that are really community and family kind of owned and led, they're the ones who are really kind of generating the insights and the learnings. And then we're just ensuring that we are really open and listening and then incorporating that moving forward. So there's so many different ways that we have kind of worked to really embed that the theory generation is something that is really emergent from family and community.
Thanks, Carly. And I just see a question come in from Rishi about as city leaders align to address specific spatialized inequities, can we speak to the role of health information exchanges in supporting data sharing, analysis, and action? I'm not certain if Rob is still on. Is that meeting?
Andy, I'm
gonna
let you jump in because
Okay.
I'm gonna go jump into that meeting. But
Yep.
Andy, you're at the center of all with Carly of all the data coordination. So thanks.
Yeah, so I think it's a great question. And in fact, it's been one that has been accelerated in many respects by the needs of the pandemic. We have worked really since late March of 2020 with our regional health information organization, who oversees our health information exchange, to ensure we have data capabilities to inform responses to the pandemic across our region, across our neighborhoods. And we're trying to actively think about how, that partnership that, if anything, strengthened over the last 2 years, can now be leveraged to build situational awareness learning tools that can be extended from public health emergencies like COVID-19 to other complex problems like food inequity, much as Carly described, racial inequity, much as Ndidi described, problems that will be aided by an information infrastructure that partners can see themselves in and then work to act within. And so the HIE is very much a part of that equation, along with healthcare systems, hospitals, social service agencies, and community partners. Carly, I think I saw you come off mute.
Yeah, I was just going to mention that we have, I think, had a role in catalyzing a number of different democratized data initiatives here, but not so much in our role as an HIE, but because of the capacities and the capabilities that we have as a result of being an HIE. And so there have been multiple endeavors in which we have specifically not leveraged health information from inside our own health system, because that would have created barriers to sharing, but rather put that aside, instead brought ourselves to creating infrastructure for data sharing and accelerating those by being generous with showing up where we need to show up in order to create the things that need to be created in the world.
So I see Damon gets the last question. So are we learning with other communities? And the example is absolutely yes. You probably saw a notation of All Children Thrive periodically. across the screen. All Children Thrive is what we call our local citywide learning network, but it is also connected to other city learning networks also under the All Children Thrive frame. We've had representatives from Pittsburgh, we've had representatives from across California, and then we also learn with other organizations through our roles with the Institute for Healthcare Improvement. So lots of cross-city, cross-state, and in some ways even cross-country collaboration. I think there's a lot we can learn from one another. So I know we're at, oh, Ndidi, quick. Yeah.
Sorry, just one other
Yeah.
way that we're learning, at least regionally, our accountable care organizations here in Ohio, we have a pretty strong partnership and meet regularly and are sharing learnings and are using our collective influence to inform how we advocate to the Ohio Department of Medicaid. So that is a really exciting way in which we are learning and trying to improve together.
All right. Well, we are at 3:01. Thanks everybody for attending. We are happy to be a resource and would also welcome the chance to learn from all of you. And then everybody hopefully go enjoy the mindfulness end to our day, and see you at the next day of this wonderful conference.